introduction, and then I'll be joining for the discussion.
You're most welcome.
Thank you.
We can start?
Good evening. My name is Murat Akova. I'm an infectious diseases physician from Hacettepe University School of Medicine, Ankara, Turkey. I'm sorry that I'm not able to join you tonight, but virtually I will speak about antifungal stewardship for invasive fungal infections. These are the headlines of my talk. Actually, I'll be talking about antifungal stewardship, and then a little bit I will mention about breakthrough invasive fungal infections and how to manage them. And finally, what is new in the antifungal pipeline, so new antifungal drugs. Now, if we start with the antifungal usage, well, we most frequently use antifungals either empirically or preemptively, so up to 60% or even higher percentage of antifungal usage by empirical or preemptive use. Usually, intensive care units, oncology and hematology units are the highest usage for antifungals. However, adherence to guidelines is usually low in real life. It's around 65% in a paper which I mentioned in this slide. On the other hand, inappropriate use is very high. For example, in a study in Thailand, reports 70% of all antifungals have been used inappropriately. And the most important use, inappropriate use, is for urinary isolation of Candida. On the other hand, if you consult ID physicians, that would increase appropriate usage. Now, let's talk about how to implement an effective antifungal stewardship in an hematology unit. So this chart has been proposed by Patricia Munoz in Spain a few years ago. And as you see here, at the top of the pyramid, there is bedside intervention. So to go and see the patient, this is the most important part. But if you go to the bottom of this pyramid, you should first create a collaborative group on mycosis and antifungal treatment. And obviously this group would include some hematologists, ID physicians, and I will mention to the composition of this group. Then you have to identify who are using antifungals in your hospital, then create an educational program, create guidelines, if possible, create pharmacy alerts when a new antifungal is prescribed, and then you will be able to go and see and check whether the prescription is appropriate. And then, of course, you would require rapid serological and molecular diagnostic tests, and at the same time, you would require an effective radiology department in order to identify the fungal infections. A few years ago, we published in Journal of Antimicrobial Chemotherapy, and it was all about a multidisciplinary team for managing patients with invasive fungal infections. And in this paper, we proposed this scheme. So in the middle, hemato-oncologists would be the team leader because these are the owners of the patients. And then in your group, you would include infectious disease specialists and several other subspecialties, including pulmonologists, clinical pharmacologists, pathologists, radiologists, and obviously a mycologist or a medical microbiologist. Well, there will be other subspecialty sections, obviously nursing staff who are knowledgeable about fungal infections, and surgical specialists as well. Well, unfortunately, the things are so complicated as shown in this slide, and we don't have a magic button on which we press and then immediately it says whether there is an invasive fungal infection in this patient or not. But we need to use some algorithms for identifying our patients for treatment. Now, let's start with this. This algorithm has been proposed by Samir Agrawal in United Kingdom more than 10 years ago, but it's still an effective algorithm even for today. So you start with a population at risk for invasive fungal disease, and either you apply a prophylactic regimen or no prophylaxis. At the end of the day, if your patient develops fever and if you suspect invasive fungal infection, you may treat these patients with empirically or with a diagnostic-driven strategy. So let me detail these two strategies. The empirical strategy is actually is used to buy time until you have a proper diagnosis for your patients. So in a typical setting, your patient will have refractory fever between 3 to 7 days, and then you look for clinical features, then you will start empirical treatment. But at the same time, you will use your diagnostic procedures in order to make a proper diagnosis. But by the meantime, if you have a response to your empirical therapy, and either you have a proper diagnosis or not, you can adjust your treatment. You can either stop your treatment if your patient recovers from neutropenia, or if you have something susceptible, you can step down your therapy and you can discharge your patient. But this is, as I said, to buy time until you have a proper diagnosis. On the other hand, in diagnostic-driven strategy, you would require some tests, a CT scan, if bronchoscopy is available, bronchoalveolar lavage, galactomannan tests, so on and so forth. And if it's available, a PCR test would be very useful as well. So all these tests and the CT is normal, then you can easily and effectively rule out an invasive fungal disease. However, there are several options, as you see on this slide, and it might be an abnormal CT, and the screening tests, for example, galactomannan, could be positive, and then you would have a probable invasive fungal disease. Then you would treat these patients with an effective antifungal therapy. And in between, there are several options. But in each case, you would require some sort of further fungal diagnostic tests, and eventually that would lead you either treatment, a diagnosis of probable invasive fungal infection, or further review your treatment. Now, what are the differences between those two regimens? Let's start with the empirical treatment. The empirical treatment has advantages that it covers most of the pathogens because you're using a broad spectrum antifungal agent like liposomal amphotericin B. And in that setting, patients with invasive aspergillosis usually get early treatment because you are starting without further delay. And you would not require a galactomannan screening. If your setup is not suitable for a rapid result for galactomannan screening, then you should use empirical treatment. However, there are several disadvantages. This approach is only available for neutropenic patients. And obviously, some patients would get unnecessary antifungal therapy because those patients will not have invasive fungal infections. And since this approach is only for febrile patients, the afebrile patients with invasive fungal infections will be left out. On the other hand, diagnostic-driven therapy is applicable for both neutropenic and non-neutropenic patients. And if your patient has invasive aspergillosis, this would be diagnosed properly and the patient will get appropriate therapy. And then you would avoid unnecessary antifungal therapy. However, this strategy is only applicable for invasive aspergillosis, not other molds or candida. And this would require fast results for galactomannan and PCR testing. The usual only one-day results should be available. And if this is not available, this strategy may cause delay in therapy, and that might be related to increased mortality. But so far, there was one single randomized controlled trial comparing empirical versus preemptive antifungal therapy. This was by Catherine Cordonnier from France and published in Clinical Infectious Diseases in 2009. And according to this therapy, empirical therapy provides survival advantage only in patients with induction chemotherapy, as you see here. And obviously, if you use empirical therapy, this group, those patients receiving empirical therapy, will have fewer invasive fungal infections as compared with a preemptive treatment group. A more recent meta-analysis and systematic literature review, which was published a couple of months ago in Open Forum Infectious Diseases, looked for several articles, and including 17 articles comparing the role of diagnostic-driven antifungal stewardship with empirical management. Eventually, they found out that the diagnostic-driven strategy will reduce antifungal consumption, and eventually that would reduce your antifungal cost, and there might be some improvement in mortality-related outcomes as well. This was in 3 studies indicating that. So it depends what type of possibilities you might have in your institution. So for example, if you have all available diagnostic tests, including galactomannan, PCR, beta-D-glucan, etc., then you can choose a diagnostic-driven strategy. But if these tests are not available, or some of them are available, but you might get results in a delayed timetable, then probably you should choose empirical therapy. And if none of these tests are available, of course, your choice would be prophylaxis without waiting the invasive fungal infections to develop. On the other hand, if your patient is non-immunosuppressed, your strategy would be targeted therapy. Now, in the second part, I'll be mentioning about breakthrough infections. Now, in this article, you see a comparison between breakthrough infections in the upper part of the slide. This is under voriconazole or posaconazole prophylaxis, and below is non-breakthrough invasive fungal infections, invasive mold infections. You see the main difference in the upper part and the lower part is, in the upper part, in breakthrough invasive fungal infections, there are more mucorales, there are more other molds. These are rare molds, actually usually resistant molds, and more fusarium and scedosporium species. Aspergillus is only 1/4 of all isolates. Whereas in non-breakthrough invasive fungal infections, almost half of the isolates are Aspergillus, mostly Aspergillus fumigatus, and the other molds, including mucorales, fusarium, and rare molds, are in minority as compared with the breakthrough invasive fungal infections. Now, there are 2 scenarios for breakthrough infections in hematology patients. The first is during the induction chemotherapy, and usually these patients have been under antifungal prophylaxis. In that case, this prophylaxis will prevent most of the invasive fungal infections, so the frequency will be less. And if it develops, it will mostly invasive aspergillosis with high fungal inoculum, and this might be related with suboptimal antifungal therapy. For example, reduced serum levels of azole antifungals. And there might be some genetic predilections for these infections as well. There have been some polymorphisms have been described which are related to create tendency for invasive fungal infections. In the second scenario, the patients will have refractory leukemia, have been on steroid therapy for long term, and relapsed GVHD. So these usually leads to more frequent invasive fungal infections, usually infections with non-Aspergillus molds, and there have been a significant host factors, host damage, like in GVHD. These patients have been on prolonged steroid therapy and usually have persistent neutropenia. Now, how we are going to treat these breakthrough infections in different scenarios. So here is the remission induction therapy. This is called early breakthrough infections with high fungal inoculum exposure. And then this is usually Aspergillus. In the reinduction type, it's late breakthrough. These patients have been characterized with persistent cytopenia, relapsed malignancy, prolonged corticosteroids, and these are usually Aspergillus and non-Aspergillus species. Well, coming to the diagnostics, in both scenarios, you should have detailed diagnostics for identifying the fungal agent causing breakthrough infections. So these diagnostics would include CT of lung, plus minus sinus CT or brain CT. Within 48 hours, up to 72 hours, you would require an early bronchoscopy, getting bronchoalveolar lavage, looking at the galactomannan and PCR tests in these fluids, antifungal susceptibility testing if your culture grows any fungi, and then if necessary, you would require biopsy and culture from the lesions. So it requires a very detailed examination. How you're going to treat it? It depends the type of antifungals used before breakthrough infections. So if you were using posaconazole or isovuconazole, you should check the blood levels first, and then various risk factors for breakthrough infections. Then usually switch to a different triazole. If it's posaconazole to isovuconazole or isovuconazole to posaconazole, and then add liposomal amphotericin B until you have an accurate diagnosis. And as you see here, using voriconazole or echinocandin will lead a similar suggestion, switching to a different kind of antifungals and add liposomal amphotericin B. So this has been proposed by Dr. Lainoikis in clinical infectious diseases, adding liposomal amphotericin B until a proper diagnosis is made. Well, of course, the breakthrough infections can occur while patients have been on liposomal amphotericin B, particularly Aspergillus terreus or Aspergillus flavus would cause these type of infections. Then you would switch to voriconazole plus minus echinocandin or voriconazole instead of isovuconazole instead of voriconazole. Now, let's have a detailed look of different antifungals with a foreign body infection, for example. So if it's fluconazole, if you have a blood culture positive yeast tests, then if your isolate susceptible to fluconazole, you should remove the foreign body and then switch to liposomal amphotericin B or echinocandin. On the other hand, the patients under fluconazole prophylaxis or therapy, if there is a lung infiltrate indicating mold infection, then you would switch to liposomal amphotericin B or voriconazole. The scenario for voriconazole is very similar. In the blood culture, if you culture yeasts, candida or other yeasts, and if the isolate is susceptible to voriconazole, you should remove foreign body and check voriconazole blood levels. If your isolate is unknown, then you switch to liposomal amphotericin B or echinocandin. If the lung infiltrates indicating mold infection under voriconazole therapy, then you would directly switch to liposomal amphotericin B. A very similar strategy for posaconazole eventually leads to liposomal amphotericin B therapy and then removal of foreign body if this foreign body is present, of course, in these patients. Well, therapeutic drug monitoring is usually essential if you are using azole antifungals, because these antifungals may not reach adequate serum levels if the patient does not respond the antifungal therapy. So here are the suggested serum concentrations for voriconazole. It should be between 1 to 6 milligram per liter. If you exceed 6 milligram per liter, there will be toxicity. If it's below 1, then your therapy will be ineffective. For posaconazole, if you're using prophylaxis, it should be over 0.7 milligram per liter. And if you are treating your patient with posaconazole, it should be over 1 milligram per liter. The toxicity is not an issue, which might happen with voriconazole in that case. Now, for the echinocandins, if you have a positive blood culture test for yeasts, the isolate is susceptible to candin, then you should remove foreign body and then switch to liposomal amphotericin B or eventually voriconazole for follow-up therapy. And if the lung infiltrates indicating mold infection, in that case, again, you have to switch your therapy, liposomal amphotericin B or voriconazole. For amphotericin B, as I mentioned earlier, the switch to another class of antifungals like a triazole, voriconazole, or echinocandin would be the choice. But of course, if there is a foreign body, you have to remove this foreign body as well. Now, in the final part of my talk, I would like to talk a little bit about the new antifungals, the antifungal pipeline. Well, the antifungals which I'm mentioning here, those four, rezafungin, ibrexafungerp, olorofim, as fosmanogepix, are in phase 2 and phase 3 trials. So they have not been approved yet, but they have been tested in clinical trials. So let's start with the pharmacology. Rezafungin is an echinocandin, so it inhibits beta-glucan synthase, and it has a very long half-life, 130 hours, 99% protein binding. It penetrates CNS very poorly, so you cannot use it in CNS infections, and it's excreted into the biliary system. So since it has a very long half-life, it can be used once weekly IV, and it has a very good safety profile. The second one, ibrexafungerp, is a 3-terpenoid, but it's like an echinocandin. It inhibits the beta-glucan synthase. It has a high oral bioavailability, up to 50%, 20-30 hour half-life. It has poor CNS penetration, and it is excreted in the biliary system. It's an oral drug, good safety profile, no drug-to-drug interaction. The third one is olorofim. It's a totally new antifungal. It's called orotomid class of antifungals, and it inhibits the enzyme dehydroorotate dehydrogenase. It has a high oral bioavailability, up to 82%, up to the 20-hour half-life, very high protein binding, but this drug penetrates CNS very well, and it's excreted into the biliary system. It's an oral and IV drug, and no drug-to-drug interaction with a good safety profile. The last one is fosmanogepix. It's a prodrug. Actually, it's converted some phosphatase into the human body to monogepix. It's a new drug, again, glucose phosphatidylinositol pathway inhibitor. Has a very high bioavailability, more than 90%, but short half-life, 2 to 3 hour half-life, penetrates very well into the central nervous system, and it's excreted into the biliary system. It's an oral and IV drug and no drug interaction. So these are the spectrum of activity of these new antifungals. So you see, rezafungin, it has activity against candida, but if this candida is echinocandin resistant, rezafungin has no efficacy. It has a high efficacy against aspergillus, either wild type or azole resistant aspergillus. However, unfortunately, it has no activity against mucorales. So none of these new antifungals have reliable activity against mucorales, and only monogepix has some activity against fusarium species, but all of them are active against aspergillus species, irrespective of the azole sensitivity. So this is the new scenario. If these antifungals will be available in future how they are going to be used. So I'm not going to go in all these details, but I will just mention a few selected ones. Let's start with the yeasts. So if you have an infection with invasive candidiasis caused by azole-resistant Candida species like Candida auris or Candida glabrata, currently we can use echinocandins and lipid amphotericin B, depending on the in vitro susceptibility. But future options, there are three: rezafungin, ibrexafungerp, and fosmanogepix. If you have an invasive candidiasis caused by an echinocandin-resistant Candida species, like again Candida auris or Candida glabrata, now the options are azoles and lipid amphotericin B, liposomal amphotericin B, but in future we will have ibrexafungerp and fosmanogepix. Now, let's have a look at the molds. If you have an invasive aspergillosis caused by azole-resistant aspergillus species, now we have lipid amphotericin B. Well, sometimes echinocandins might be used, but liposomal amphotericin B is usually the only choice. But next, in future, we will have olorofim and fosmanogepix for this indication. Ibrexafungerp and rezafungin will have efficacy as well. Well, for mucorales, unfortunately, there is not many options, and currently we should rely on liposomal amphotericin B and to some extent posaconazole and isovuconazole, while fosmanogepix might have some efficacy, but it's not reliable efficacy. And as you see, the drug interactions and toxicity, most of these new antifungals will be available because they are safe and they do not have drug-to-drug interactions. So before concluding, I would like to mention and underline once again, the management of invasive fungal infections require a teamwork. In the center, there is hematologists, and in the satellite, you would require infectious diseases physicians, mycologists, and the other sub-specialties. In the setting where you are treating your invasive fungal infections, the site-specific factors are extremely important. So you should know about the incidence of invasive fungal infections, availability of certain tests like PCR, galactomannan, etc., and the epidemiology of emerging resistance in your setting. Well, on the horizon, there are new antifungals and they may provide alternative therapy. However, unfortunately, except for mucormycosis, but for these drugs, long-term safety data are missing, and we don't know anything yet about the resistance development and their efficacy in severely immunosuppressed patients. So I should stop here, and thank you very much for listening to me, and I will entertain any questions you might have. Thank you very much again.
Thank you so much for this very nice presentation. Any of the audience would like to ask any questions related to fungal infection or related to? Okay. Anybody would like to ask any questions? Okay, I just want to ask you a very simple question that will only last for 1 minute. Are you using combination antifungal, or as usual we keep it for a very last choice?
Well, actually, we never use antifungal combinations in our primary antifungal therapy. The most certain, I would say, indication would be central nervous system aspergillosis. So in that case, you can combine, well, liposomal amphotericin B with voriconazole, for example, because the mortality would be very high for this type of aspergillosis. But otherwise, I mean, we don't use antifungal combinations.
Thank you so much. And it was our pleasure to have you here, and sorry for everything. Thank you so much for everything.
Thank you very much. Thank you. Thanks for the invitation.
Our next speaker is going to be Jihaz.
كبروفيلاكسس مع اللاينز اوف تريتمنت اساس مثلا بيبقى عندنا هاي سسبيليتي اننا نبقى انفكتيف او يعني في انفكشن يعني are they using this in Turkey or just for Egypt?
I don't know. Are you still here online? She's asking
Yes,
whether
I'm online, but I'm afraid I missed the first part of the question. Could you please repeat it?
Okay. Some centers uses the antifungal as a prophylactic first line of treatment side by side with the antibiotics. Is this applied to your country? Or
Well, actually, I mean, we have in our hematology population, we have two indications for antifungal prophylaxis, and we usually use posaconazole for that. First, it's the induction chemotherapy, those patients who are receiving induction chemotherapy with acute leukemia, usually AML. And second, in those patients who have severe GVHD. In that case, we use posaconazole. For allogeneic stem cell transplant recipients, before engraftment, we usually use fluconazole.
Okay.
That's
Thank
all.
you so much. Thank you so much.
Any other questions, please? Thank you, Mr. Murad Nukover.
Thank you very much.
Next speaker.
Have a successful meeting. Thank you. Bye-bye.
Thank you so much for this informative lecture.
Yes, next speaker is going to be my dear colleague, Professor Dr. Yusuf